Well, let me start by thanking Dr. Patel for having me. It's a wonderful meeting, and over the last couple of days, we saw extensive amount of coronary artery disease, and so today, for a change, I'll show you some angiograms that don't have any coronary disease because you need a break. So the topic is MINOCA in the Cath lab, mistakes and misgivings. And we'll just cover MINOCA in general. So when we think about coronary artery disease, and we think typically this is what comes into our heads, angiograms that look like this or look like the angiograms you've been looking at for the last couple of days with extensive disease and CTOs and tight lesions and bifurcations, et cetera, et cetera. And these patients present with different types of presentations, from asymptomatic all the way to acute coronary syndromes with a lot of angina in between. And I'm going to try to convince you that you can have angiograms like these and still have coronary artery disease, just a different form. And these patients also can have acute coronary syndromes and can have angina or unstable angina. And so the idea is that we need to dissociate the myocardial ischemia or myocardial injury from obstructive coronary disease. Of course, the majority of ischemia and myocardial injury is caused by obstructive disease, but the two terms are not synonymous. They're not the same thing. You can still have ischemia without having obstructive epicardial disease. This is not very surprising if you think about it, because we know that 90% of the coronary artery circulation is not visible to us. We only see on the angiograms arteries that are 300 or 400 microns in diameter, and 90% of the coronary branches are actually smaller than that. So we don't see all this. But we can definitely study it in different ways, but not necessarily visualize it. So from this came the term INOCA, or ischemia with no obstructed coronary arteries. And over the years, a more standardized diagnostic criteria were developed. Basically, INOCA means that patients have symptoms such as, by definition, they don't have obstructive epicardial disease. They have evidence of ischemia on functional testing, like a stress test or a nuclear scan. And they have evidence of microvascular dysfunction, which we can study in the Cath lab or by PET scans. These patients don't always have the very typical exertion or effort angina, but they have features of angina in their history, and it's really important to take a good history from them. The obstructive coronary disease used to be defined by diameter stenosis, although nowadays I think we should incorporate also FFR and IFR to establish that the epicardial disease is not obstructive. They don't always have abnormal stress test results, because our stress tests generally are made and designed to detect variability in regional perfusion. They're not made to detect reduction in perfusion across the board, which is what we see in cases of microvascular dysfunction. And we study, as I said, microvascular dysfunction both by PET scans and MRI, as well as in the Cath lab by invasive testing. So this is INOCA. We modify the term to MINOCA, or myocardial infarction without obstructive coronary arteries. And it basically is the same thing, except that these patients, instead of presenting with symptoms of ischemia, they're actually presenting with an acute myocardial infarction, a typical rise and fall of troponin, with ischemic symptoms, ischemic EKG changes, presence of thrombus on their angiograms, or having evidence of myonecrosis on imaging. They also, as by definition, don't have obstructive disease in the epicardial arteries, and they don't have other causes of myocardial injury. So, for example, myocarditis or stress-induced cardiomyopathy or cardiac contusion, other things that can cause a rise of troponin or injury to the myocardium are not included in this definition. This definition applies to ischemic injury. They also exclude the supply-demand mismatch, which can cause injury but by a different mechanism, basically by the increase in demand rather than the reduction in supply. So this doesn't qualify as the standard ischemia per se. So MINOCA is actually not rare. So 6% of all acute myocardial infarctions come without obstructed epicardial coronary arteries. So if we think about STEMIs and non-STEMIs, any interventionalist will probably see this within the multiple times within a year for sure. The types of myocardial injury are, as seen on this pie chart here, are either ischemic and obstructive coronary, as we see. We've been watching the, and these are the majority. The majority we do. There are thousands of cases in which there is, meaning troponin elevation, but that injury is caused by ischemia or caused by non-ischemic pathophysiology. With non-obstructive disease, which are the patients we're talking about today, we know that their profile is a little different from or more women in this population. They're typically about a decade on average. They have less hyperlipidemia, but they have the other risk factors of CAD with the same prevalence. Typically, they present more with non-STEMI than STEMI, but both are included. Typically, their infarctions are not as large, so their troponin peaks are not as high. Their prognosis is not benign, meaning their prognosis, their 1 year risk of death is in the 3-4%. The patients with obstructive disease, maybe the risk of death at 1 year nowadays is in the 6 to 8%. But that's not the same as somebody who did not have an elevated troponin. So it is not as bad as obstructive disease, but not totally benign either. It's important to understand, and I'll talk about this in detail for the rest of the presentation, is that MINOCA is not a single entity. MINOCA is sort of a term that we use, or a working diagnosis that we use to a number of pathophysiologies, and it's really important to distinguish between these different pathophysiologies because their treatments are very different. Typically, it is very hard, or not very hard, I should say, it is typical or more common that we need more than one test to reach the result or the final conclusion or the final diagnosis. That can start in the cath lab and be followed by non-invasive testing, or it can be vice versa. It's sometimes not easy to distinguish between ischemic and non-ischemic injury. It's important to know that, because even though sometimes the clinical presentation seems to be quite obvious, it actually surprises us how often we can be wrong. This is a nice meta-analysis of a number of publications, 46 publications as you see on the slide, looking at MINOCA cases that underwent magnetic resonance imaging of their myocardium. And this included about 1,800 or 2,000 to 2,000 patients. And only 1/4 of them, 26% of them, we could really establish evidence of ischemic myocardial injury, at least by the definitions we use. About 1/3 of those patients actually have MRI evidence of myocarditis. So what we started out thinking of as an MI was actually not an MI. It was a non-ischemic injury caused by myocarditis. And not a small fraction also has stress-induced cardiomyopathy, which seems to be an MI, and many of us or all of us have seen this until you study them further and realize that it's a reversible cardiomyopathy or Takotsubo cardiomyopathy. Another thing that's interesting too is that about 1/4 of those patients did not have any evidence of myocardial abnormalities. This is a little tricky here because the MRIs for those types of patients will need to be done usually within the first 2 weeks. Once 2 or 3 weeks pass, the yield of MRI imaging becomes much less. And so when you look at a retrospective meta-analysis of a large number of studies like that with no standardized definitions, you may be getting a little bit of a skewed picture. Having said that, it is just to make the point that it's a working diagnosis, it's an umbrella term, and that we need to dig deeper and break down this MINOCA into its different entities. These are examples of ischemic and non-ischemic injury on MRI. When you see this brightness, this gadolinium enhancement in the subendocardium, right at the junction between the myocardium and the lumen, that is the typical or the pathognomonic feature of ischemic injury. That's what we define as ischemic injury, subendocardial gadolinium enhancement. When the enhancement is in the middle of the myocardium or subepicardial, meaning that there is space between the gadolinium enhancement and the lumen, that tells you that this is not of ischemic nature. This is typically what myocarditis looks like. This is a patient who I actually saw 2 weeks ago. She is actually a physician who had 2 bouts of MINOCA, meaning goes to the emergency room with chest pain. She gets admitted, her troponin goes up, goes down, she undergoes a cath, she has no epicardial disease. Then she comes to see me to figure out why she has these episodes. And we get an MRI because her latest episode was only 10 days before I saw her, so we thought that there was an opportunity to get a good yield on the scan. And without repeating her angiogram for a 3rd time, we can see that the distribution of enhancement here is not ischemic at all. She's having recurrent bouts of myocarditis. This is subepicardial with those 3 arrows and mid-myocardial in the septum, as you can see there. But none of this enhancement is subendocardial, which is definitive in our mind that this is not ischemic in nature. So the most likely scenario that most of us will see those patients is that they come in and are diagnosed with an MI in the emergency room or in the hospital, and they're waiting to get an angiogram. And they get an angiogram, and when they get the angiogram, they don't have epicardial disease, and this is when the process is sort of defined. We have the MI definition by the troponin rise and fall. We now have the angiogram that doesn't show epicardial disease, and so we get into this situation in which we now need to sort out what happened. Why did this patient have troponin elevation? And we use all these tools, the angiograms obviously, and we use our intracoronary imaging as you have seen and learned over the last few days, and we use some physiologic testing as well. The one thing that we do that I think we should do first is make absolutely sure that there is no epicardial disease. And that may sound easy, but sometimes it's not that easy. Angiograms are not as accurate as we think they are, and if we don't do our due diligence in getting good angiography, we may miss things. And even if we do pay attention to all the details, sometimes we still miss things. This is a patient who was referred to me for a study of microvascular dysfunction, and the angiograms look like mild irregularities here and there. So we put our wire down in the LED because that's how we do our microvascular testing, with a pressure wire in the LED. But the IFR is, as you see here, 0.7. So there's something wrong here. Something is not right. There's some obstructive disease in this LED. And there are 2 bumps, as you see there, which means that there are 2 focal lesions, it seems. We can only see on the angiogram there's a little bit of haziness at the bifurcation of the septal trunk, so maybe there's some calcium there, but it didn't look obstructive. But the following step, as you might expect, is intracoronary imaging to try to see what is going on and where are those pressure bumps coming from. And this is what we see on coronary imaging. The distal reference where the yellow arrow is, there really isn't that much plaque. But where the blue arrow is, there is a bifurcation lesion. That's a tight lesion with a minimal lumen area of 3 that's hidden by this bifurcation. And if you look at that hazy segment, there is a shelf of calcium, or as we learned from Dr. Patel and Dr. Akazaka in the last few days, nodular calcium. So this patient actually has epicardial disease, and her non-STEMI was caused by an obstructive lesion, just like everybody else, except that it just wasn't as clear on the angiogram. And so this patient was considered for a mammary bypass or for stenting, and ended up getting one lung stent to cover that segment. So the specific causes of MINOCA, as you can see here, may be related to epicardial pathology that is not necessarily caused by obstruction, or may be related to microvascular pathology. And so plaque rupture, plaque erosion, in-stent in situ thrombosis, or Scad are some of the pathologies that can be seen in the epicardial arteries. Microvascular pathologies would include things like epicardial coronary spasm, which has some microvascular or endothelial bases, and microvascular dysfunction. So I won't talk too much about in situ thrombosis because it's quite rare, and we all know what supply-demand mismatch is. We'll talk a little bit about those other pathologies that you see here. So plaque disruption is very common cause of MINOCA. About 50–60% of cases are caused by plaque disruption. Angiographically, these patients have some mild haziness or irregularity. Sometimes you don't see anything at all on the angiogram. But definitely, by definition, they don't have severe diameter stenosis. There is a difference between plaque rupture and plaque erosion. And plaque rupture means there is some discontinuity in the surface of the fibrous cap. Plaque erosion usually means that we don't see the discontinuity in the fibrous cap, but we do see evidence of a thrombus contiguous with the lumen. So here in figure A, you see a break in the fibrous cap, and you see the plaque cavity now evacuated because of blood flowing through it. So that's a plaque rupture. B, you see a thrombus with the underlying surface not really, at least not clearly showing any breaks. So that is what we call plaque erosion. This is a case that we have seen in the last few months. I think a woman in her 40s with a non-STEMI. And we don't see much here on the angiogram. We saw in the cath lab maybe the resolution is a little better than the slide, but we did see a little bit of haziness in this area. So we decided to image this area. And what we saw here, I'll play this video for you. And as we pull back across that branch, we could see there's a little bit of thrombus there, and I'll show you. This is the still frame. So an intraluminal thrombus, we can see through it a little bit. It's causing a little bit of shadowing, but it's not completely red, more of a bit of a more white than red, although maybe there is some shadowing. And there is some haziness in the surface underneath, but it doesn't look like a complete break. So we defined it as plaque erosion. And this is the explanation of this woman's non-STEMI. Plaque erosions tend to cause the myocardial injury by distal embolization. Typically, these thrombi are not obstructive, but they do embolize into the smaller branches downstream. The second pathology is spontaneous coronary dissection. It's a form of arterial vasculopathy. It's strongly associated with fibromuscular dysplasia. The incidence of it is very difficult to define because it depends on the population you study, but it's definitely more common in women, and it's definitely a significant problem in women under the age of 50 presenting with acute infarctions. Depending on the phenotype, they can be difficult to diagnose sometimes angiographically. And intracoronary imaging is usually diagnostic, although it sometimes is not wise to try to wire and instrument these arteries because you can't extend the dissections sometimes. It's important to know or diagnose the Scads because Scad doesn't respond very well to PCI, and it may be wiser to let those arteries heal on their own. This is the classic angiographic description of the different types of Scad. I'll just ask you to point your attention to 2A. 2A is the type that is actually more common, in which there is a little bit of tapering. In this case, it looks quite tight, but sometimes the tapering is not as severe and may be missed. So it's important to have that in mind, especially women, especially younger. And when you look at the angiograms in all of these pictures, you see there really isn't that much atherosclerosis anywhere else. This is the case that example that I'm showing you, a large circumflex system with a little bit of tapering in the distal part of the circumflex where the terminal posterolateral branches are, and Scad tends to happen in the distal segments as well, which is not typical of atherosclerosis. In one view, it looks more impressive than the other, but if you look at the areocaudal, it doesn't look that impressive. But the OCT imaging here shows clearly that there is a significant intramural hematoma of the wall with the catheter and the lumen sort of separated from the external elastic lamina. And you see that the branch point here is coming from the true lumen, which is why the artery looked and its branches looked all open. This is how it looks on IVUS, very similar intramural hematomas, compressing the lumen, and that's what causes the tapering. This IVUS was not from the same patient, although it looks very similar. The last couple of things I'll talk about are microvascular dysfunction and vasospasm. Microvascular dysfunction is more common in women, especially in middle age. The pathophysiology is related to remodeling or fibrosis or rarification of the microvasculature. There is a form of microvascular dysfunction that's called functional, and it's caused by dysregulation of nitric oxide synthase. It's normally defined as a CFR less than 2.5 or less than 2, and the microcirculatory resistance of more than 25. You can diagnose that using PET scans or MRI. This is a typical table you get at the end of your PET report that looks at CFR or myocardial blood flow ratio, which is equivalent to CFR, looking basically at myocardial blood flow at peak hyperemia divided by myocardial blood flow at rest. And typically, or normally, it should be more than 2. And the PET scans, you can use the kinetics of the tracer, the rubidium in our place, to calculate this. In the Cath lab, we use the pressure wire X and the Coroventus software to calculate microvascular function, and this is what we call a bolus thermodilution technique, and we calculate the transit time of flow at rest and the transit time at peak hyperemia. And the CFR, as you see there, should be more than 2. In this case, it's 4. The IMR should be more than 25, less than 25, and here it's 12. So this both are normal. This is an example of what CMD would look like. The CFR is low. The IMR is high. This patient was presenting with effort, angina, and dyspnea on exertion. Spasm is more common in men, especially in Asia. I think this may change as we study spasm more in the Western world. I think most of the studies came from Japan for a long time. It has some association with smoking and inflammation. The pathophysiology is related to hyperreactive smooth muscles and dysfunctional endothelium. You can induce spasm in MINOCA patients at a much higher rate than you can induce it in patients with large vessel disease, although the definitions used in these studies were quite different. This is an example of a non-STEMI patient who we saw with mild atherosclerosis, as you can see here. And she came to us about 2 weeks after her event, so we thought it was safe to do acetylcholine provocation. And this is what happens when we induce with acetylcholine or provoke with acetylcholine. You see that we can induce spasm in the LAD right distal to the diagonal and diffuse spasm distally in the distal parts of the LAD. And with that, we were able to reproduce her symptoms, and we were able to show the EKG changes that are consistent with ischemia as well. Acetylcholine half-life is very short, so the spasm would last for only a few seconds. We typically, when we see that, or if the patient is having pain, we can give intracoronary nitroglycerin to reverse it, but even if we don't, it will resolve on its own within a few seconds. So how do we treat those patients? Obviously, the pathology is very different, and we'll treat the cause. It's important because when we see them, we don't have the definitive diagnosis right away to assume that they have an acute MI. Treat them as an acute MI. So we treat them with DAPT, with statin, with beta blockers, whatever you treat acute MI by medically. After the diagnosis is made, that obviously will change the direction. If there is a plaque disruption to explain it, like the erosion or the rupture that we showed, you treat them with the same things, and you focus on secondary prevention with high-potency statins and risk factor management. If it's Scad, you focus on beta blockers. Statins may not be necessary. Aspirin may or may not be necessary. Probably not, but definitely beta blockers. Scad tends to recur. 25% of Scad patients will have another episode of Scad. And so beta blockers are the only things we know that can reduce the risk of recurrence. Coronary microvascular dysfunction, we treat with beta blockers, specifically the types that enhance nitric oxide synthase, so like nebivolol or carvedilol. We use ACE inhibitors because they improve endothelial function. We're very aggressive with statins and aspirin as well. With vasospasm, we focus on calcium channel blockers. We use nitrates typically as a secondary agent, and spasm also typically happens in patients with mild atherosclerosis, so secondary prevention, again, is important. Non-pharmacologic treatment and cardiac rehab and diet and exercise are also very relevant. So I'll conclude by saying that MINOCA is not rare. It's a spectrum of causes that lead to myocardial injury, more in younger women. Non-invasive imaging is really important, and we focused on MRI because it's probably the most accurate myocardial imaging tool. Invasive or intracoronary imaging in the cath lab is really important, and OCT has the highest resolution, and that's why it gives us the best yield. Microvascular endothelial-based abnormalities typically require another procedure for further investigation. Thank you very much.
Khalid, there is one question from my end. I mean, in Cleveland Clinic, what are the indications of using intracoronary imaging in a case of MINOCA?
If the patient qualifies or satisfies the definition of MINOCA, we will use intracoronary imaging.
Okay, it means
almost everyone.
I mean, troponin high and proper
presenting with chest pain, rise and fall of troponin, and we can't see anything on the angiogram, then we will.
And which imaging you use?
In these cases, OCT is better.
Okay. Thank you.
Quick question, Khalid. Most of the data that we have on prognosis of MINOCA patient predates the high sensitivity troponin. So are we overdiagnosing it now, or do we know what we are doing when we get a typical rise and fall with HS troponin?
Yeah, so that obviously is, it's a tough question to answer. I think you're right. I think we may be diagnosing it more. The question is more mean overdiagnosis or more means more accurate? So I think one of the criteria for the definition is having ischemic symptoms. So, you know, if you have a, you know, if somebody goes to the emergency room nowadays and their ankle hurts, they get a troponin elevation, they get a troponin assay. So obviously, in the absence of ischemic symptoms, you probably can take that, sort of put it aside a little bit. But in the presence of chest pain or dyspnea associated with that troponin rise and fall, I think they meet the criteria.
Okay, thank you very much again.
In plaque disruption, sir, in plaque ruptures,
Please,
is it like can we go ahead without stenting that area if there's a plaque rupture?
Yeah, so by definition, these cases are non-obstructive, meaning that they don't have narrowing. So there is a bit of a debate as to how to, if treating them, stenting them is necessary. There is an argument for stenting them because that can lead to what's called plaque passivation. So you sort of prevent this further activity of the plaque by creating this layer of neointima on top of it. But I don't think this is very well established. In the absence of an obstruction, meaning a diameter stenosis, it probably is reasonable to treat them medically.
Sure, sir. Thank you.